I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Welcome, everyone, to the November 2016 PRS Journal Club podcast. I'm Amanda Silva, and I'm joined by my fellow resident ambassadors, Sammy, Sinno, and Raj Sawh-Martinez. Today, we welcome our guest discussant, Dr. Bill Adams from Dallas, Texas. We'll be discussing an article by Dr. Robert Allen Jr. out of NYU entitled The Profunda Artery Perforator of PAP Flap, Experience for Breast Reconstruction. The PAP flap was first introduced for breast reconstruction in 2010, and the authors present their extensive experience with this flap. They've performed a retrospective review of 96 patients who underwent 164 PAP flaps from 2010 to 2014. The authors go through the key steps in surgery in the methods section. Briefly, all patients who underwent surgery had preoperative imaging with either MRA or CTA. The patients initially marked in a standing position with the superior margin at or just below the inferior gluteal crease, and then they're placed prone to ID key perforators with a Doppler. In the discussion, the authors mentioned that the key perforator can usually be found an average of 5 centimeters below the inferior gluteal crease and about 4 centimeters from the midline, and there's usually 2 to 3 perforators. The inferior border is then marked about 6 to 7 centimeters below the superior border, and then the lateral border is at the lateral aspect of the posterior thigh, and it's carried medially about 30 centimeters. Figure 1 shows the markings for this flap. The flap is then harvested in the supine position with the patient frog-legged. However, the authors did mention that the first 6 flaps that they performed were harvested prone. They dissect from medial to lateral in the subfascial plane, just posterior to adductor longus, and then reflect the gracilis anterior. And as the adductor magnus fascia is entered, that's where the perforators are encountered. Figure 2 shows the key steps in this dissection. The flaps were then anastomosed to the internal mammaries and then coned if it was inset for 1 flap, or if they used 2 flaps, they just sutured them to one another. And if they were stacked, they would hook them up antegrade and retrograde external mammaries. Table 1 shows the patient demographics of patients who underwent this flap, and of note, the average BMI was 23.3. Table 2 shows the reconstructive timing. About half of the patients were immediate reconstructions, and about half were delayed, with the majority of the delayed following a prior failed reconstruction, including 14 failed free flaps, 12 which were abdominal based. Table 3 shows the flap characteristics. The average flap weight was 366 grams, which corresponded relatively well to the average mastectomy or implant weight of 364 grams. Flap dimensions were on average 27 by 6 centimeters. The average pedicle length was about 10 centimeters, and the average artery and vein diameter were 2.2 and 2.6 millimeters, respectively. Of note, 6 of the PAP flaps had additional modifications at the time of the initial surgery. 5 of the flaps were reconstructed using a stacked PAP and deep flap, and 1 was augmented with an ICAP or intercostal artery perforator flap. In 1 case, 2 PAP flaps were used stacked for a single breast. If you look at figures 3 and 4, these show the pre and post-op photos of patients. And then of note, for revision, stat grafting was performed in 80% of the patients with an average volume of 175 cc's. And the authors didn't specify if this was just at the recipient site or also at the donor site, which is noteworthy because they mentioned that the scar and contour of the donor site can be a disadvantage of this flap. They do, however, mention that only 10 flaps required greater than 200 cc's of fat grafting, which according to the authors is the average amount they use for abdominal-based flaps. The flap take-back rate was 3%, and there was 1 flap loss due to a technical error in flap harvest that was salvaged with a deep flap. Other complications included a 1.9% hematoma rate, a 6% seroma rate, 7% fat necrosis rate, and a 1.9 donor site infection rate. The authors concluded that the PAP is an excellent alternative to the gold standard DEEP, especially in patients who have inadequate abdominal tissue, previous abdominal surgery that would preclude a safe harvest, or simply prefer to avoid an abdominal scar. And this is best used for small to moderate sized breasts. So overall, I think this was a great paper, from people who have by far done the most PAP flaps. And so someone who wants to consider doing this flap for a reconstruction for a patient, I think this is a great paper to reference. One of the things that I was hoping to see a little bit more, and that I've heard from other surgeons who have tried to do this, that closing the donor site can actually be kind of challenging with the patient positioning. So that was just something I would have liked to maybe see a little bit more detail on. But I would open the discussion now, specifically Dr. Adams, if you've tried doing this flap or heard from your colleagues who do breast reconstruction, any pearls or thoughts on trying to pursue this flap?
When I was doing a lot of free flap breast reconstruction, this flap has not even been described yet. So I don't have any personal experience with it. But I think the paper is a good one. It details things very nicely. The one question I have for you all that we can talk about a little bit is they certainly acknowledge that in the paper about the donor site. The interesting thing about the thigh, not necessarily even as a donor site, but if you look at aesthetic surgery, where people have gone with the thigh in terms of thigh lift, horizontal excision has been almost completely abandoned in terms of any kind of cosmetic thigh lift. It's all gone to vertical type thigh lift because of the donor site. And I'm interested to hear what you all think about that. I don't know if there's vertically based flaps that you guys have done for breast reconstruction, but the paradigm of breast reconstruction in the past, certainly 10 years, has really shifted, right? It's almost a reconstructive aesthetic procedure. And so not only the breast needs to look good, but you want the donor site to look good too. And I think the only limitation of this flap that I see is the donor site. I don't know what you guys' thoughts are.
What about the vertical upper gracilis and those vugs and tugs? Are those any better with donor site morbidity? And are those vertically, some of them can be vertically based as if you're designing similar to a medial thigh lift on a vertical incision, right, Amanda?
Exactly, yeah. But we do some vugs at UOC, and it's, again, the donor site. I mean, you have a big scar. The scar usually widens. You usually have contour deformity at a relatively small flap. So it's an alternative for someone who isn't a good candidate for an abdominally based flap, but it's usually not the first go-to. I mean, at least in the photos, which, you know, of course, the photos are always the best photos you put into your article. The donor site doesn't look too bad, but you don't have any lateral views, so it's kind of tough to see the deformity.
I've done a few of these here with the attendings at NYU, and Nick Haddock and Robert Allen, Nick Haddock, who's a surgeon in Dallas now, wrote up the original paper in PRS in 2012. And, you know, I think the donor site is something that's definitely significant. I think the authors will tell you that. First of all, as you alluded to, it's very difficult to close, and even just checking the incision on rounds is very difficult, frankly. You know, ideally, the patient's almost seated on rounds so you can really see the extent of the incision. And I think you can see from the pictures that if everything heals nice, it's acceptable, but I think it's not ideal. To answer your question, in addition to the gracilis-based flaps, Dr. Adams, I know that Dr. Allen also does a LTP or lateral thigh perforator flap, but that's laterally based and also has a pretty significant scar. I think the key thing with these flaps that it's in the appropriately chosen patient that really has a paucity of abdominal tissue or is going to augment that abdominal tissue. And Dr. Allen is so facile at raising free flaps. Oftentimes they'll do a 3-team approach where you'll have the mastectomy surgeons, another set of surgeons harvesting the deep flaps, and the third set down in the leg harvesting the PAPs. So it can be super efficient and really done in series or used to add volume, but I think there is some definite downsides to this flap, one being the lack of tissue in most patients. You saw the low BMIs, and 2, the donor scar.
Yeah, from our Yale experience, you know, I'd sort of totally agree. I think that, you know, the positives here are absolutely that it's, a great adjunct. 2, I think that it is fairly well hidden. And Dr. Adams, you know, you're absolutely right. The orientation of the scar isn't the greatest, but it is hidden for these patients sort of in their pants line, underwear, and it's not as visible, even as sometimes the abdominal scars that we would get from abdominally based autologous reconstruction. But, you know, when we think of the PAP, at least here, it's always sort of one of the secondary options. You think of the other secondary options, latissimus, kind of the main standard secondary option. But I think what makes this a challenge or less ideal is having to potentially change positions intraoperatively. You guys there, like you're saying, Sam, you have 6-7 people doing the cases all at the same time and going together. So it probably makes it a lot more reasonable. But, you know, if you're a single surgeon in the community doing autologous reconstruction, it's probably not your favorite when you're having to flip the patient back and forth and doing all that stuff sort of on your own. So I think there's some variability, but I think it's one of those things that we're learning from the experts in this article and having an inner armamentarium as plastic surgeons so you can reference this and seeing when to choose the right patient for it and when it can work.
Raj, you mentioned position change. I think they actually can do it all supine now. They started doing it prone, which would involve the position change, but now they're harvesting these supine. I would be curious, Sammy, since you have been in a few of these, how exactly do you guys close the donor site? You just put the leg up, or you just like bent over?
It's a lot of external rotation and a lot of traction and a lot of assistance. I mean, you can't do it by yourself. You have to have an assistant really helping provide traction and holding the legs in the appropriate position.
You guys use lithotomy
elevation
as well?
Well, not quite. More like frog-legged, and then sort of elevating if necessary. The tough thing to do, as you all know, at the end of the case, you're trying to get things close up well, but that's sort of the time when you've finished the micro and everyone's trying to move it along. So it's usually a team effort, but it's not pleasant. The most unpleasant thing is checking the incision on rounds because everyone's excited to close, but the next morning with a gog can be really, really tough to check the incisions. But we are doing them a lot, and Amanda, you'll see quite a few of them next year when you come.